moving on to our next speaker.
So we have done with sepsis a lot of ECGs. Now let's see the most interesting topic of imaging studies, which is quite important for all the ED physicians, is a CT brain. I'm sure most of you will be a little surprised. How do I finish CT brain within 20 minutes? But at the end of this session, I'm sure you'll take a lot of messages. I've made it very simple. A lot of pictures there. The whole point is to just identify basic anatomical structures which will appear on the CT, and there are only few life-threatening conditions which are quite important. Remember, I am not a radiologist here. I am an emergency physician. Okay, we all know CT brain plays a very critical role in emergency room. It is quite important investigation on daily basis of our practice in order to pick up quite a few traumatic and atraumatic neuroemergencies. Again, I'm not here to make you radiologist. Instead, to interpret CT brain systematically, like how we read ECG with steps of rate, rhythm and axis. Not all hospitals will have a radiologist or a neurologist on call 24/7. So it is very important for the person who is working in the ED to interpret these life-threatening lesions and make sure that he informs his neuro team so that the brain can be saved. Before that, we all know, just to summarize, brain is made up of two frontal lobes, parietal lobes, occipital lobes. There is a central brain stem which is made up of midbrain, pons and medulla. Anatomy is very fundamental and basic, without which we can't go further. At the same time, there are a lot of physics and terminology like attenuation, z-axis, voxels, pixels and all, which is of not much of important for this session. Instead, we just go with CT. What is CT all about? It is just X-rays which are taken at multiple sections. How we take an X-ray of a chest. Similarly, X-rays are taken at multiple levels of the brain and scalp, and these X-rays are pushed to the computer and we get a CT brain. So in simple, it's just X-ray plus computer is what we call CT brain. Okay, X-ray, there will be a source which will be pushing X-rays to the patient, and at various degrees and densities, the tissues absorb these X-rays, and there will be a detector which is opposite to the 180 degrees opposite to the source, that will take all this information and push to the computer, and then we get the typical CT brain film. Denser the object, most of the X-rays are absorbed, and very few X-rays reach the detector and it appears whiter. Whereas least dense is the object, most of the X-rays are transmitted, so it appears blacker. If I can ask you, which is the most dense object in the body? It's the bone, is it not? So bone appears more whiter, whereas air in the sinuses, it appears least dense, and hence it is given -1000 Hounsfields and +1000 Hounsfields. So these taking into consideration, acute blood will appear slightly less whiter than the bone, and your CSF will appear slightly less blacker than the air. Thanks to this gentleman, Godfrey Hounsfield, who did a lot of things to the CT, and hence all the units have been given after his name. Have you all seen this image in your CT room? So this is gantry. This is the main source for the CT. It has a source and a detector, and the patient is put on the table and moved to and fro. X-rays are bombarded to the patient at the same time at 360 degrees in a spiral way. At the same time, the detector will be opposite to the 180 degrees opposite to the source, and whatever information it gets, it will push to the computer and we get an image. Generally, the X-rays are taken slightly at the slant way, and whatever we get, it will be reconstructed by the computer and we get this image. Have you all seen this image? Yes or no? if you see this image, my question is, from where do we start from, correct? So let's begin our CT bully, okay? So if you go close to this image, every image there is a picture like this. So this picture is called as scout film or a scout image. If I zoom this picture, you can see there are a lot of dotted lines, is it not? You're appreciating these dotted lines? This is called z-axis line. Usually the lines are slightly at a slant, okay, and these lines start dissecting the skull and the brain into multiple slices, and this also helps in calculating the volume of blood. You might have seen a radiology report, 3 into 4 into 5 ml of blood is there in this place. So these z-axis and the slices will actually help this. Each slice is roughly around 5 mm, so that gives us the breadth, and the width and the height can be calculated in the computer, and that's how we get the volume. The next thing is, the z-axis starts cutting from the level of the mastoid. It keeps going up and it goes and it starts cutting up to the cortex. So if I correlate my anatomy, the z-axis starts cutting from the lower portion of the brainstem, that is medulla. It keeps going up, and it keeps cutting the thalamus, then it goes up, cutting the cortex. So if I recollect again, brainstem, the lower portion will be the medulla, above it will be the pons, and above it will be the midbrain. Posterior to the pons we have fourth ventricle, posterior to that is your cerebellum. Again, if I correlate, the first structure, okay, it will be what? Will be the lower portion of the brainstem, that is medulla. So the first structure which we get is the medulla. So how do you remember this? So you remember the shape of an apple, okay? So if you go closely to this image, okay, so this is, shape of the apple, and this is your medulla, and posterior to that is your fourth ventricle, posterior to that is your fourth ventricle, and which is filled with CSF, that's why it appears more blacker, and posterior to that is your cerebellum. Now anteriorly there are again CSF filled spaces, which is called a cistern, and usually it is below the level of the pons, hence it is called as infrapontine cistern. Now if I put a contrast, okay, at this level of medulla I can see two vertebral arteries, okay. So what is the first structure we are getting here? It's a apple shaped structure, which is medulla, okay. So now the question is, what will I get next? What will I get next? Pons. Now the pons, is this pons? I don't know. So let's see and look at a key which identifies the pons. So if you closely observe this structure, okay, which is slightly inverted U shape, for all boys you can remember this picture, which is a mush, correct? Who is the famous cricketer here? Is a Merv Hughes, is a Australian cricket bowler. So when you see a mush-like appearance on a CT, that means you are at the pontine level, okay? For all girls, you can remember teeth, okay? So, and this is your pons. The roots of the teeth are the peduncles, and the enamel and the pulp or dentine will be your pons. So the roots will be peduncles, and the enamel and the body of the tooth will be your pons. Now again, if we recollect your anatomy, posterior to the pons is fourth ventricle. This is your fourth ventricle, which is filled with CSF, and anteriorly you have again a cistern which is jacketing the pons, and this junction is called as cerebello-pontine angle, and this is your cerebello-pontine cistern. Now if I put a contrast, and you get a basilar artery. So two vertebral arteries will combine to form one basilar artery. So this is your pons, this is your peduncles, this is your fourth ventricle, and this is your cerebellum, and this is your cistern. Okay, you're all appreciating this? Yes or no? Yes. So once you identify this mush, where is your mush here? Is this mush? Yes or no? Can you appreciate a mush appearance here? Yes. So can you appreciate a mush here? Yes or no? No? Yes? So as you go up, we need to focus on the midbrain. So let's see how midbrain looks on a CT. If you can again focus here, this structure appears, okay, similar to a cartoon. I have given a clue. Which cartoon does it belong? And it also starts from MI. So it's a Mickey Mouse. Huh? And the ears is your pons, the mouth is your cerebral aqueduct, and if you closely observe, there are two projections here at the midbrain, and this is called as colliculus. Okay? And these two projections are inferior colliculus. If I say there are two inferior colliculus, there should be automatically two superior colliculus. So the cistern which surrounds this, will be your quadrigeminal cisterns. There are four bodies, two superior and two inferior colliculus. So that's why it is quadrigeminal colliculi, and the cistern which surrounds this is your quadrigeminal cistern. Now anteriorly again you get a cistern, and that is your suprasellar cistern. This is a star-shaped cistern where your circle of Willis stays. At the same time you can see this is a W-shaped cistern. Okay, so where is your Mickey Mouse? Is it right? You can appreciate a Mickey Mouse here, right? Pons, your mush appearance. So let's go to see ventricles, thalamus and basal ganglia and other cisterns. We all know ventricles are two lateral ventricles, 1/3 and 1/4 ventricle, and this is your anterior horn of lateral ventricle. Lateral ventricle has two anterior horns, two posterior horns, and sometimes you can appreciate temporal horns. So this comma-shaped structure is again filled with CSF. Ventricles will be filled with CSF, that's why it appears black. This is your third ventricle, and this is your again quadrigeminal cistern, or you can take it as basal cistern. Now how do I identify thalamus? If you can closely see here, this is a V-shaped structure, okay, which also takes the shape of the boomerang. This is your internal capsule, okay. This is your anterior limb, posterior limb, and the junction is your genu. Again, this is your anterior horn of the lateral ventricle. This is your third ventricle. Now, any structure lying between the anterior horn of the lateral ventricle and the anterior limb of the internal capsule is your caudate nucleus. So, this is your internal capsule, anterior limb, genu and the posterior limb. So a structure which lies in between the anterior limb of internal capsule and the anterior horn is your caudate nucleus. Similarly, a structure which lies between the posterior limb of internal capsule and the third ventricle is your thalamus. Now the structure which is lateral to the genu or the internal capsule is your lentiform nucleus, which is compromised medially by globus pallidus, laterally by putamen. So medially you can remember as Mahatma Gandhi. So MG medial is globus pallidus, LP lateral is putamen. So on a CT if you see, again this will be your anterior limb, genu and your posterior limb. There you go, that's your lentiform nucleus. Globus pallidus will be medially and putamen will be lateral. Head of caudate nucleus comes here, which is at the junction between the third, between the anterior limb and the anterior horn of the lateral ventricle. And your thalamus stays in between third ventricle and the posterior horn of the lateral ventricle. I know that you are all concentrating on the left image. Please concentrate on the right image. So coming to how to identify your Sylvian fissures, the two eyes will be your Sylvian fissure. The nose will be your third ventricle, and your smiley face will be your quadrigeminal cistern. Let's see how CSF drainage. So CSF usually drains from posterior horn of the lateral ventricle, goes anterior. From there it enters the aqueduct of Sylvius. It enters the third ventricle. From there it goes through cerebral aqueduct through fourth. From the fourth it goes into subarachnoid space through foramen of Lashka and Magendie. Now any obstruction here to the flow can cause hydrocephalus. So it can be either due to SOL or blood. When I see an image like this can be still physiologically present in infants or age atrophic patients. Now when I see an image, I need to tell whether it is physiological or pathological. So how do I do that? I have a formula for that. So you need to compare the maximum skull diameter at the parietal distance, interparietal diameter, and maximum distance between the two ventricles. So interventricular distance and the maximum interparietal distance. You divide the ratio B by A, and if it is more than 4, usually it is normal. Say the B diameter is 10 and A diameter is 2. So 10 by 2 is 5. So it is normal. Suppose if the A keeps increasing, suppose A is around 5. So 10 by 5 will be 2. Definitely there is a pathological dilated ventricles. So you should look for either blood or SOL. Now if I see a temporal horn, usually temporal horn of the lateral ventricles are not seen. Usually these are again comma shaped structures on the temporal lobe. So if I see this, that indicates that it has a obstructive hydrocephalus. We have covered the cisterns. There are 4 major cisterns. There are many cisterns. 4 major. One is supracellular, above the level of the pons. One is peripontine cistern, which is surrounding the pons. Infrapontine cistern, below the level of the pons. And you have a posterior to the midbrain, a quadrigeminal cistern. Now, if I see a cistern, I should clearly see it should appear like a black, because it is filled with CSF. If it is not clearly seen, that means it will be filled either with blood or edema. In this side, if you can see, you can't appreciate any of these cisterns clearly. So acute blood appears brighter. Acute blood appears hyperdense or whiter, and here if you can see, okay, there is blood at the level of what? This is an internal capsule, anterior horn of the lateral ventricle, third ventricle. So there is a right thalamic bleed at the level of thalamus. There is acute blood in the right thalamus. Usually it can be secondary to hypertension. Okay, all right. So we have seen, what is these lines? These are all z-axis lines. Again, what are these? What is the first structure you will get? Medulla. What is this structure? Pons. What does it resemble? Tooth. Okay, what is this structure? Mickey Mouse. Mickey Mouse is midbrain. So what is this? The blue-shaped cistern? It's a quadrigeminal cistern. Now let's see a few other aspects, neurological emergencies. So we all know most of the supply to the brain is by anterior circulation, which is filled by ACA and MCA. Posterior circulation is basically takes just 1/5 of the supply, which is by the posterior cerebral artery. Now, when I see an image like this, how do we identify an infarct? So usually infarct appears hypodense. It appears blacker. And if I see an arterial infarct, I should comment whether it is ACA, PCA or MCA. So what you need to do is just draw an imaginary line, anterior V line up and the inverted V line down, and the anterior portion, whatever comes, is the anterior cerebral territory. This is your posterior cerebral territory, and in between will be your middle cerebral artery territory. Now here if you can see, there is a hypodense areas which is in middle cerebral artery territory. So when I see infarct, I need to comment whether on 3 things: whether there is a mass effect, whether there is midline shift, or if there is any cerebral edema. So mass effect means that side ventricles will be obliterated. You can't see the ventricles this side, correct? No. So here you can see which territory does it belong to? ACA, MCA or PCA? It's a MCA territory infarct, and it is compressing that ipsilateral ventricle. So mass effect is definitely there. And midline shift is the lesion is pushing the ventricles or pushing the brain to the opposite side. Now we need to know when do we call a significant midline shift. So for that we may have to draw an imaginary line across the falx from the anterior point to the posterior point, and you draw a perpendicular line at 90 degrees from the junction of the ventricles. So if this distance is more than 5 mm, that means it is a significant midline shift. The third aspect is when you call it has cerebral edema. So generally sulci and gyri, which is appearing on the right side, should be seen clearly. If you cannot appreciate sulci and gyri, that means there is a cerebral edema. Okay, cerebral edema is due to protein filled fluid, that's why it appears more whiter. So that's why all the sulci and gyri are disappearing. Coming to traumatic injuries, EDH is arterial bleed. We all know it is extradural hemorrhage. How do you remember? Remember Hidley.
2 more minutes left.
Yeah, two more minutes. Idli, I have 5 slides, that's it. So, idli shaped is your EDH, and it is generally associated with fractures, doesn't cross the suture line. SDH again, so again our hero comes back, the Bahubali hero. So, that is your sickle shaped structure or a concavo shape structure. Generally, it crosses the suture line, and this is venous bleed. When you comment on bleed, we need to know how it is, what effect is going to cause you. So the villain is here. So when we need to see where it is. So if you see here, this is what, EDH or SDH? So it is a idli shape, that's why it is EDH. Whether it is compressing the ventricle or no, so there is a mass effect, and at the same time it is causing midline shift. So acute blood will appear whiter, whereas subacute blood, which is 1 week, will appear isodense. That is, the density of the whitish thing will keep going, and it becomes more blacker and blacker. Hypodense bleed will appear more black. This is because as the globulin molecule will get damaged, the whitish thing will disappear and you get blacker. So this is your SDH. You can see the demarcation. This is your SDH, again causing mass effect and midline shift. Again, this is also SDH. Do not confuse it as an infarct. Infarct will be territory based. This is an SDH, which is a chronic bleed. So usually it will be 2 weeks old. Subarachnoid hemorrhage, I hope yesterday we had a good time, gala dinner there. So you need to remember wine glass. So if you see a wine glass appearance with lot of blood which is spilled across the brain tissue, or there is a sign of hydrocephalus with cerebral edema, that means it is a subarachnoid hemorrhage. You can appreciate here as well, it is a subarachnoid hemorrhage. Here you can see it's a Mickey Mouse. There is no, it is at the level of the midbrain, there is no cistern seen, that's why it is a subarachnoid. Sometimes blood can also appear in the ventricles. This is your intraventricular hemorrhage. You can see the anterior horns are filled with blood. You can't see sulci and gyri, which is cerebral edema. Again, there are temporal horns which you can see, which indicates that there is a obstructive hydrocephalus. The last thing is your skull fractures. So your cut-up is back here. So it can be hidden things. When you see skull fracture, you need to comment on whether it is linear fracture or depressed fracture. Linear fractures are slightly better because it's just a crack. Usually it will be associated with EDH. We need to more concentrate on evacuation of EDH. Depressed fracture is more significant when the segment is going and compressing inside in such a way that the width of the segment is more than outer and inner table. When you see depressed fracture, you should make sure that you alert your neurosurgeons, make sure that you take off the segment as early as possible. When you comment on fractures, you need to look at pneumocephalus, which is air pockets within the parenchyma. So this is your air which is pitch black. Okay, so you can see this is your CSF, whereas air is very pitch black. So when you see pneumocephalus, that indicates there is some crack which is leaking into the environment. That indicates there is a open skull fracture. How do you treat that? So this can lead to infection of the brain meningitis or encephalitis. So you need to treat this with triple antibiotic and oxygen. So at the end, you need to know, after looking at all these anatomical structures and various lesions, so you need to have your own mnemonic. So the mnemonic can be as simple as that. Blood can be very bad. So first look at blood, whether is there any EDH, SDH, what is it causing, whether there is midline shift, mass effect or cerebral edema. Then look at cisterns, whether they are seen or not seen. Brain parenchyma, whether it is having a cerebral edema or no. Then ventricles, if there is dilated or no. Then you look at skull fractures. If none of these are there, then you can take it as there is no emergency on a CT, and you can safely take calls from the neurosurgeon.
You are finishing your time.
Yeah. The last slide, just to remember, HAPL is for medulla, tooth for pons, very good. I see the lot of Mickey Mouse is for midbrain, and sickle shape for SAH, wine glass. And last but not least, so that's your quadrigeminal cistern. And don't forget this gentleman, Godfrey Hounsfield. So like ECG, we need to keep repeating. It's not just today. You need to go back to your medical schools or the hospitals, keep looking at various CTs. So that's how you practice, that's how you become more perfect on the CT. Thank you.
And as you all know, for emergency physicians, this has become a very basic investigation because time is so precious once they come with hemorrhage or infarct. So every young generation physicians are supposed to know the intricacies of CT. As he explained, now this session is open for questions for a couple of minutes.
So I believe most of things are basics here. I have not gone detailed. The take-home message will be how to identify the anatomical structures and few life-threatening lesions like EDH and all. Second important thing which I want to tell you is acute stroke patients will not see this kind of hypotenuse lesions as you saw in the CT. Generally, CT is used only to rule out bleed before we thrombolize acute stroke.